You heard from Emily that I started out my career about 30 years ago as an animal control officer, and I worked in an animal shelter and animal regulatory authority in the rural Pacific Northwest. Very different kind of place from the animal shelter that I have in the same building that I work in now for the MSPCA. This was the kind of place where we took in, on average, over 50,000 animals a year. And unfortunately, a lot of those animals never made it out of our animal shelter. So that had a real shaping and formative experience for me and really started me thinking about a lot of this stuff, and is part of the reason why I ended up spending my veterinary career once I finished veterinary school and did my postgraduate training, why I have spent the rest of my career working in advanced veterinary medicine, but in the very odd context of a nonprofit animal welfare association, the Massachusetts SPCA. And that really changes things. So I'm going to talk a little bit more about that. So over the years that I've been doing this work, and now I would say particularly in my 12 or 14 years that I worked in emergency critical care medicine at Angell, and now the over 10 years that I have worked just in pain and palliative care practice, lots and lots and lots of ethical questions have come up. And like many people who are interested in ethics, that really pushed me to start thinking about ethics in a more systematic way, and eventually led me to get training as both a clinical ethicist and as a more theoretical ethicist. So let me start off with a little bit of a definition. Ethics is a philosophical discipline pertaining to notions of good and bad, right and wrong, our moral life and community. Bioethics is the application of those things, that discipline, to healthcare, to the life sciences, to biotechnology, and somewhat enlarge that definition to include anything relating to living things in our environment. So ethicists and bioethicists in particular are much more likely to ask questions and challenge some of the norms in society than we might be, unfortunately, to offer practical suggestions. Clinical ethics goes a little bit further towards the practical side of things, and that's what we're really going to be talking about today. So for me, and I think for a lot of other people who have gotten involved in bioethics, my own personal moral distress was a real motivator to me and really was a reason why I became interested in this subject. And I think for those of you who have learned about compassion fatigue, you may realize that moral distress is a big reason why a lot of people who are caretakers, who work in caring professions, end up with compassion fatigue. And that was very apparent to me. I particularly like the idea that bioethics gives us guidance in professional situations for how we should handle our own actions and what we should expect of others when we are in difficult situations. And I would say that our colleagues in human health care have spent the last 30 or so years thinking pretty critically about this. And one of the things that was really obvious to me when I started being trained in bioethics is that human health care has a whole lot of organizations and infrastructure to deal with ethical conflict that those of us in veterinary medicine don't have. For me, the thing that was most interesting was a system called clinical ethics consultation. And I'm going to give you an example of an ethics consultation a little bit later on in the talk. And this is something that I have translated into my own work. And we have an ethics consultation service at the MSPCA, and something that I hope I'm going to see happen more and more in veterinary medicine. But I'll give you a little bit more information about that soon. Unfortunately, there are limits to what bioethics gets you. And it is a system, even though it's a structured system and it's a system that you can use for practical guidance, it's not always the easiest thing to translate into the daily questions that come up during practice. And it doesn't give you a right answer. But it does give you a way to talk about and analyze and think about what some of the right answers might be. So before I delve into some of the specifics of these issues that I'm working on, I've been thinking about this stuff for a long time now, about 30-some years. And I have, as I've thought about it, realized that there's some underpinnings, I think, that have really raised the ante in veterinary medicine about the kind of ethical conflict that we see. I think the biggest thing that we all probably recognize is that companion animals mean different things to society than they used to. And even in the course of my own practice, I see Alan is looking at me skeptically. Okay, I'm going to try to prove this. I think that we know in the course of human history that animals have always been important to people. And probably people have had intense relationships with individual animals throughout the course of human history. I think what's different now is that now it is much more socially acceptable to talk about the relationships that we have with individual animals, to acknowledge how much they mean to us, and the fact that we can grieve over them. That's different. And I think part of the reason that that's different is because human society is different. A majority of people in the world now live in urban environments. That is new for human society. And I would say a majority of people, or maybe not a majority, but many, many more people are delaying childbirth and living singly for large parts of their life. And that was not common in times not very long ago. So I think it makes sense that our relationships with animals are different and are much more important. The other thing that I've seen just in the time that I've been in veterinary practice is that the average age of the patients that I see is a lot older. As I said before, my practice is exclusively pain and palliative care. Most of my patients are well into their teens. I just, for example, yesterday, I saw an 18-year-old dog and 3 16-year-old dogs. And I would say at the beginning of my time in veterinary medicine, that would have been really unusual. That's my normal day now. When your patients live that much longer than they used to, there's a lot more time for chronic illness, there's a lot more time for chronic pain, and there's a lot more time for things to happen in the relationship with the people that care for them that may cause conflict. I think the other thing that I recognize that has changed this equation is that there's been an explosion in neurobiology. We know so much more about animal cognition and animal emotional lives than we used to. And I think for people who think about this stuff, and I would say for me, that's been kind of dismaying in some ways to have all of my suspicions about how complex animals really are confirmed by neuroscience, because now I have to think about stuff that may cause suffering that I didn't used to think would cause suffering. And that has really changed the way I conduct my practice. I think the other big factor that has changed ethics in companion animal medicine is that people expect different things from medical care for themselves, and consequently they expect different things for their animals' medical care. And there is much more of an expectation that when we go to the doctor, we have a role, and maybe in some cases we actually dictate what kinds of diagnostic testings we ask for, what kinds of treatment we have, what kinds of things we reject. And in my own practice, and I think in a lot of specialty medicine, we see more and more clients who now expect the same kind of role in their animals' health care. So one of the things that I learned when I first was trained in bioethics that really hit a chord to me was that a lot of ethical conflict in medicine is about a clash of values. And when I thought about that from a veterinarian's perspective, I realized that in veterinary medicine, when we have conflict with pet owners over what's the right thing to do, we usually frame it in medical terms. So for example, very often I have conversations with people who are facing complicated diagnostic workups for their elderly and sick animals. And they are really struggling with what's the right thing to do. So they come to people like me and they ask me what should they do. And what typically happens in that scenario is a veterinarian talks about what are the risks for complications from the anesthesia, from the procedure itself. Or the veterinarian and the owner might talk about how much is this going to cost and what's that going to mean in terms of being able to afford further cost. But what we miss a lot of times is that that's not really why they're asking us what they should do. A lot of the stuff that makes them ask us what they should do is non-medical. It's things more along the lines are, is it going to damage my dog for him to be in the hospital for the day that he has to be there to have all those tests done? How can I live with the guilt of putting him through that? It's basically non-medical values questions. And I think that is a place that we don't think about a lot of times. When I think about sources of ethical tension in veterinary practice, I boil them down to these 4 big categories. And let me give you a couple examples of these things so you know what I'm talking about. When I say differences in the belief about the importance of animals, I'm thinking about the way people morally rank animals. For example, I was walking down the street in Boston a couple of weeks ago, and I walked past a house, and I saw in the window of the house a very extensive habit trail. Really, somebody took a lot of trouble to environmentally enrich their mouse or hamster or gerbil's life with this very elaborate structure. And then I looked, and I noticed underneath the window, on the outside of the window, was one of those black plastic boxes used to catch and trap and poison mice. And I thought, that's a pretty good example of the difference in ranking of importance of what might actually be the same kind of animal. But there's a whole bunch of other ones like that. Do we owe more care to companion animals compared to wild animals? Do we owe more care to a service animal than we do to a pet animal? Okay, the next one, our responsibilities towards animals. What do we expect from pet owners? How much do we think pet owners owe their animals in terms of medical care? And how much do we as veterinarians owe medical care to those animals? Are we obligated to provide free care? Are we obligated to provide care or insist on care if somebody can't pay for it? If we move on to differences regarding the veterinary professional's role, I'm going to talk a little bit more in detail about this later on, but some of the questions that I think about in this regard are, do we have the right as veterinarians to refuse to do certain treatments or refuse to offer certain tests? Should we be the ones who initiate end-of-life discussions? Should we suggest euthanasia to our clients? And then a big category for me is differences regarding the interests of animals. Who decides what's in the best interest of our patients? Is it the people who technically own them? Is it the people who love them and care for them? Is it us? Are we the moral authority in this equation? And where is that line drawn? So let me give you an example of a values difference. I have a colleague who practices outside of the United States, who's a veterinary cardiologist. He has developed a new treatment for a congenital cardiac lesion. And this is a congenital heart disease that affects many breeds of dogs. And in dogs who have this heart disease, their lives can be shortened dramatically if they have this disease in its severe form. Dogs who have this disease in its mild form usually can be treated with medication and live a fairly normal life, although their life might be somewhat shortened. My colleague told me about a situation where he has a client who has a young Labrador Retriever that has this heart disease, was born with this heart disease, and his client knows that he is trialing this new procedure, but this procedure is very risky, and there is a real risk of death or harm when this procedure is employed. And as of to date, my colleague has only offered this procedure to patients who have a severe form of this disease. This client, whose dog has a very mild form of the disease, is insisting that his dog have this procedure because he wants to give his dog the best possible chance for a normal and long life. So my colleague and his other colleagues in his cardiology department are now having a discussion about whether or not they can say, no, we're not going to perform this procedure in your dog because we think the risks are too high. Or should they acquiesce to this owner's wishes, even if it is not in agreement with their own? Don't have an answer yet for you on that one. They're still talking about it. And sadly, I don't have an answer for most of these things. So I don't have a whole lot of time. This particular set of questions are the ones that are of most import to me and are the questions that I am actively working on. So I wanted to go through these a little bit, and then if I have time, I'll give you a list of a few other things that I'm working on and thinking about. So let me just delve right into it. Okay. As you heard, most of my practice is with elderly animals, and I spend most of my day when I am seeing patients talking to people about the end of their animals' lives. So we do a lot of talking about what is the appropriate level of intervention at the end of life and who gets to decide that. And I would say that many people who seek veterinary care are surprised when they understand that a veterinarian might have really strong opinions about these things. One of the things that's been really interesting to me in exploring this is that there appears to be a very big divide between veterinarians who work in primary care practices and veterinarians who work in specialty hospitals like this one here and the one that I work in. In many cases, veterinarians who work in primary care practices and often have very long-term relationships with clients and patients feel much more likely to offer their own opinion about what should happen at the end of life than veterinarians who work in specialty medicine. And oftentimes when I ask about this, what I hear is that veterinarians who are specialists believe that if a client seeks out their special services and they have taken the extra step to see them and to go to a specialty hospital, that they don't think that it's their place to actually introduce the idea about when care should be limited. Very interesting. I'm going to talk a little bit more about my own personal opinion about what palliative care and hospice care in veterinary medicine is. And one of the questions that I think a lot about, and I would love to hear what people have to say, is hospice medicine, hospice care ethically defensible when you have euthanasia as an option? So think about that while we keep talking. So I promised you that I would explain a little bit more about clinical ethics consultation in human health care, so I want to give you an example. This is an example from a meeting that I went to last month, I think, and it's a very typical one. This was a case of a 71-year-old man, a veteran who is in the VA system, with a history of PTSD and alcoholism. This man fairly recently suffered a pretty severe traumatic accident, and he ended up with a traumatic brain injury and a spinal cord injury. And his traumatic brain injury eventually, over the course of some number of months, improved to the point where he was considered mentally competent and was communicative and retained pretty much most of his normal mental faculties. But what didn't improve was his paralysis and dependency on a ventilator. So after, I think, 8 or so months of care, it was clear that for the rest of his life he was going to be dependent upon a ventilator and not be able to move any of his limbs. So as soon as this man was conscious and his brain had healed enough and he was able to communicate, he started communicating both with gestures and with words to all of his care team that he wanted the ventilator gone and he wanted to be allowed to die. And when he was able to actually talk, he very explicitly, over and over again, made that request. So the first thing that his healthcare team did was have a palliative care consult, because whenever these kinds of situations come up for people, the first thing that they try to make sure of is that the person is not depressed, or that their pain is poorly controlled enough that that's motivating their request to have life-sustaining technology taken away. And it was determined that that was not the case for this man. His pain was well controlled, he was mentally competent, he fully understood what he was asking and what the implications were of this. So then the ethics consultation team was called in to discuss with both the family, the patient, and the healthcare team whether or not it would be ethically acceptable for them to remove this man's life-sustaining technology. And, you know, I think one of the things that was really interesting to me when I learned about this stuff is that in the United States, our legal system does not make a legal distinction between the removal of life-sustaining technology or putting a patient on life-sustaining technology. There is no difference. If you remove a patient from life-sustaining technology, particularly if the patient requests it, that is no more considered something that is criminal or murder than it would be if you did not put the patient on that technology in the first place. So we knew that there was legal reason to allow this to happen. Ultimately, what did happen is that they acquiesced to this patient's wishes. There was a long period of time where they planned for this, and everything happened the way the patient wanted it to happen. But as you can imagine, this caused a lot of distress amongst the staff of people who had cared for this man for, at this point, it was well over a year that they had been caring for this man and knew him very well. So when I heard this, as a veterinarian who deals with end-of-life cases pretty much every day of my working life, my first thought, I think, was very different from what most of the other people in the room thought. And my first thought was, wow, the patient asked for what they wanted. It was clear what this patient wanted. And to me, that would have been, you know, that is something that I don't ever get to have when I have these discussions. And it really makes it a lot easier to me, I think. But I don't think that any of the healthcare team, healthcare professionals in the room with me would understand that in this quite the same way that people in veterinary medicine would understand it. But I did also think about how would this case be different if this was a child, and how much more would that be like the kind of questions that we deal with. So let's talk a little bit more about that. I do think there's a lot of parallels. I do wonder if maybe the time is coming for us to start talking about advanced directives for pets. We don't typically in veterinary medicine devote a lot of time to talking about what's going to happen at the end of life, earlier in life for our patients. We don't schedule appointments with clients to plan this stuff. Well, at least most veterinarians don't. I think that we don't really think about it as much as maybe we need to, because now we have a lot of the same advanced technology to keep patients alive that exists for people. So maybe we do need to think about this stuff. The other thing that I think about is all veterinarians work pretty independently, and we all get to decide how much we want to talk about these things with our clients, how much we want to direct it, how much we want to give our own opinions. And one of the things that appears to be really variable between veterinarians, as I mentioned before, is whether or not the veterinarian should be the one who initiates an end-of-life discussion. So I'm very curious to hear what people think about that. I think the other thing that is really different for veterinarians compared to physicians and other people who work in healthcare is that we don't have much of a support structure to deal with grief and anticipatory grief. So the veterinarian ends up being the one who provides a lot of that support to the pet owner. And that's a very different role than a physician has most of the time. And I think that changes things. Okay, I do want to talk a little bit, this part of what I'm going to talk about is really my own opinion. I want that to be clear. And some of the stuff that I am going to say, I think, is not widely shared by other members of the veterinary community, so this is definitely my own opinion. I don't consider what I do in my palliative care practice as hospice care. And the reason that I don't is that my patients are not what is termed in people actively dying. And the other thing that I have to remind all of us of is that even though I have a pain and palliative care practice, neither one of those things are recognized subspecialties in veterinary medicine. And what that means is that there is no structured training in either one of those disciplines in our world of veterinary medicine. So these are things that have to be self-taught. A veterinarian has to gain the knowledge of these fields in their own way. And that leads to a lot of variability in the way care is delivered and the way these things are conceptualized. To me, I have a very specific definition of palliative care medicine, and it is largely 100% lifted from palliative care medicine as it's practiced for people. This is care that is provided alongside care for primary medical issues. So for example, if I have a patient who's diagnosed with cancer, or I have a patient who's diagnosed with a degenerative neurologic problem, they might also see me for a palliative care consult anytime after that diagnosis is made. Because what I'm going to do with that patient and with that client is teach them how to take care of that patient, teach them how to figure out whether or not that patient is having unrelieved pain or distress, what they can do about those things, and also what can we do about the distressing things that happen as a result of chemotherapy, for example. How do we deal with the side effects of all of the treatments that we provide? That's the way I think of palliative care medicine. It does include a very large component of meeting the emotional needs of both the patient and the caretakers. And I think that that is important. Hospice care, to me, is a very different thing. What's interesting to me about veterinary hospice care is that if we were to equate it with human hospice care, there's probably less than 10 organizations or facilities in North America that provide true hospice care. There are a couple of inpatient veterinary hospice facilities scattered around North America, but most hospice care is care that's provided in the home, mostly by pet owners. And I think that that is part of my problem with some of it, is that I think a lot of clients that I see come in and see me and tell me that their patients are in hospice care. And what I find happening is that the label hospice is applied to patients who are simply not receiving medical care. Owners have chosen to not, for all kinds of reasons, good and bad, pursue diagnostic or treatment, and they label that hospice care. But that's not really hospice care. Hospice care is when you're actually actively providing comfort and care to the patient and to their family. And I think of those as two different things. The other thing that I've found about some of the hospice care that I've shared cases with and that I've been involved in is that there is a very explicit prioritization on the family's needs. And it means that the needs from the patient's point of view may not be considered in quite the same way. The other thing that I find very commonly in veterinary hospice care is that there's a lot of talk about veterinarians euthanizing animals much too quickly, much too often, and that there is something that is inherently better about letting animals die without intervention. So I don't know if that's true or not. I think that people have very strong opinions about whether or not it is better to let an animal or a person for that matter die without intervention. I guess what I would say is, what do you consider intervention? You know, is any medical care prolonging life? And where do you draw that line? And those are the kinds of questions that I think about. So I want to move on because I am almost out of time. And I want to share a couple of other things with you. The first is an issue that I am actively thinking about and writing and talking about. And this is the idea of futile care. For those of us who work in advanced veterinary medicine and specialty veterinary medicine, more and more we are finding ourselves in situations where we are being asked by pet owners to provide care to patients who we know have a very short time to live and may not benefit at all from the kind of care that we are being asked to provide. And in some cases, that care might actually be harmful to them. This is a very well recognized and documented situation in human health care. And the reason that I have futility in quotation marks is because futility really is in the eye of the beholder. And it all depends upon what your goal is. If your goal is to keep your patient alive for the next 12 hours so that a family member can arrive and say goodbye to that patient, you may not consider it futile to keep that dog in heart failure on a ventilator and keep them alive until that patient arrives. But if you are thinking of things from the point of view of the nurse who is providing the care for that patient, who has already been on that ventilator for the last 3 days, and you know what's going to happen, it might feel pretty bad to you to be caring for this patient for another 12 hours in that situation. So I think it's important that we recognize that everybody's definition of futile care is going to be different. And because of that, in human health care, this is now mostly called non-beneficial care. We're facing the same thing in veterinary medicine, and for those of you who are here today who are practicing in veterinary medicine, I'm sure you know this. But I do think that we have to think critically about this, and I think that we have to ask ourselves a lot of questions. Again, what does this mean when you have euthanasia as a readily available option? And what does it mean when our patients are not human? I think that that is a question that is thorny, and we have to think about it in a lot of these things, because even though I am a person who considers my companion animals part of my family, and I think that I treat them with the same consideration that I would a family member, and I think most of my clients feel the same way, those family members are not the same species as me, and they may have very different needs emotionally, physically, that I might not be respecting if I treat them the same as a patient. So I want to give you a quick example of this, and then I'm going to cut it short. We had a patient in our hospital who was a mouse. This was more than a year ago, I think. And this was a very elderly mouse. I think this mouse was getting close to 2 years of age, which is pretty old for a mouse, who had a very aggressive form of mammary cancer. And this was a mouse who had already had 2 surgeries to remove breast cancer tumors and was now faced with recurrence of this cancer and spread of this cancer. The owner of this mouse was a disabled person who lived far away from our hospital and could not travel to our hospital to see the mouse. And essentially this mouse was living in our hospital for months and months at a time while receiving this care. But the owner felt very, very strongly that she did not want to stop doing everything that she could do to prolong this mouse's life. From the point of view of the people taking care of this mouse in our hospital, there was a lot of different points of views. There was a point of view of, we've come this far, why shouldn't we continue to try to keep this mouse alive and comfortable as much as possible? But there was another point of view of that this owner has not even seen her beloved pet in, at this point it was several months. She doesn't know what the patient is going through on a day-to-day basis and what their life is like in our hospital. And everybody agreed that the prognosis was very poor. So this is the kind of case where I actually got called into this case to do an ethics consult because there was a lot of distress and disagreement about what should happen with this case. And I know you want to know what happened, but I'm not going there. I will tell you all if you want to hear about it later. I do want to very quickly introduce this last idea, and then I will skip the rest. There's a very interesting idea in human healthcare that really is also a problem for us in veterinary healthcare, and the idea of people who feel very strongly that they or a family member or an animal that they're taking care of has a health problem, either a mental health problem or a physical health problem, but they may be in disagreement with other people and experts who are providing care for this patient. And some of you may remember this case, a very sad and troubling case, the Justina Pelletier case that happened in this area a few years ago. This was a teenager who was brought to Boston Children's Hospital, very disabled and very sick. And ultimately it was decided by the staff at Boston Children's Hospital that this teenager did not have the physical illnesses that her parents believed that she had. She had psychological illness that was at least partially induced by all of the medical care that she had received. When she got to Boston Children's Hospital, she had already been treated in hospitals for most of her life, and I think had been in at least 3 other hospitals long-term before she got to Boston. And this all came to a head, you may remember, when the state of Massachusetts awarded custody or removed parental custody from this family, and there was a big uproar. Eventually, this teenager was returned to her family. As soon as she was removed from the state of Massachusetts, she was immediately put back into a hospital in a different state, and I believe she's actually still in the hospital to this day. So we don't really know. But sadly, cases like this happen in veterinary medicine, and I would argue that these kind of cases actually happen in veterinary medicine more often than they happen in human health care, for obvious reasons. It's a lot easier when you legally own the patient to direct their medical care. And I'm glad that Dr. Graham is here, because the case example that I have of this is actually a case that she and I shared some years ago. And this was a case of a guinea pig who was owned by a person who believed very, very sincerely and strongly that her guinea pig had severe, significant physical ailments and also anxiety that was induced by pain and by the physical ailments. And I think when I met this guinea pig, I think I was the 5th veterinarian to evaluate this case. And when I read through the medical history and I spent an hour talking to the owner about the case, and I examined the patient, I didn't believe that the patient had a medical problem. And I thought that the patient's behaviors were normal behaviors, and that some of the behaviors that were being interpreted as anxiety behaviors probably were, but they were actually induced by the way that the animal was being cared for. This is a situation that we face pretty regularly in veterinary medicine. We used to call this Munchausen syndrome by proxy. It has a new name now, factitious disorder by proxy, and the definition has been enlarged. We're not just talking about the really extreme examples where people are actually causing illness. We're talking about cases where people truly believe that their animal or their family member has an illness and continually are seeking care. And I have a lot of examples of this that I don't have time to share with you. I'm sorry. So I'm gonna actually skip over the rest of this stuff, sadly, and just give you this little list before I stop so that we can talk a little bit. There's a lot of really interesting things happening in the world of veterinary ethics and animal ethics. And these are some of the other things that I've been thinking about and talking about. One that I really love to talk about is the consideration of the animal perspective in service and therapy animals. I think we all are in agreement that the phenomenon of service animals has been wonderful for people and many, many people have benefited from it, and I would say that many animals have probably benefited from it as well. But I don't think that we've really given serious consideration to what the lives of some of these animals are like, how these animals are picked to do what they do, and what happens to them over the course of their life. Another thing that I've been thinking a lot about is the use of pet-owned animals in scientific research. This is something that is becoming a bigger and bigger issue because animals who have owners do not have the same legal protections as other laboratory animals or other animals that are used in research. So this is something that we have to work on. But I want to stop, and I really would love to hear from any of you who have comments. And if you disagree with me, I'd love to hear that too. So what do you say? Yes?
One of the things that's obviously a problem all the time is cost.
Mm-hmm.
And when people are making decisions, most of the time it's going to be paid for, certainly by Medicare or Medicaid or private insurance. The folks that don't have it, and who are assuming that they still love their animals as long as they do as an animal, and because pet insurance is still relatively rare, that issue is absolutely in the middle of all of this.
Yes. So
You can't avoid that when you're dealing with very expensive chemotherapy and very expensive things. If everybody had pet insurance, would that change the dynamic?
So I have to say that you pointed out a glaring void in my talk. You're right. Cost, especially the ethical implications of the limits that cost put on veterinary care, is a huge cloud over all of this. And of course I don't have a great answer, but in answer to your specific question, I think we do have evidence from other parts of the world where pet insurance is widespread. For example, in the UK, the vast majority of pet owners in the UK have pet insurance, and it does change the equation. I don't think that it will ever remove from the equation, but I do think it will ease a lot of the distress that comes along with these decisions. But on the other hand, when we introduce insurance in a widespread way, it's going to change the way medicine is practiced in my world as well. So there's a trade-off for sure. Anybody else? If you have comments that you don't want to share in this larger world, please email me. I would love to have a conversation with anybody who has any reaction to any of the stuff that I've said. So thank you.